All right, today what we're going to do is do a little staff development as far as reducing joints. All right, because as athletic trainers, you know, you're all taught, splint it, ship it off, send it to the emergency room, let them deal with it. We're not supposed to. As athletic trainers here, we are under the care of, or under the umbrella of our orthopedic surgeon, who's Dr. Foreman at Azeli. He has instructed me to say the best thing for the athlete is to reduce the joint and put it back in as soon as possible. Because the longer the joint is out, the more damage is being caused. So whatever, by reducing a joint, you know, they always say that you could cause more damage, you can do this or anything. Dr. Foreman told us that it is the amount of damage by leaving it out outweighs the damage you could do by putting it back in. Does that make sense?
Yeah.
So since y'all have never actually been taught how to do it, we're going to go over 3 of the easiest reductions that there are. We're going to go over the patella, the finger, and then the shoulder, because those are the ones you're going to see the most. All right. In talking with Dr. Foreman, he also, we also talk about, knee, ankle, and elbow dislocations as well. All right. He still thinks, with a knee dislocation, there's all kinds of nerves and blood supplies and things that you have to worry about reducing that could be life-threatening. All right. He still feels that it is to the athlete's best interest to go ahead and reduce that. All right. I'm not real comfortable with doing a knee. All right, or an ankle. We were at a game and we had an ankle and he reduced it. And when you reduce the joint, there's 2 things. One, you're going to get the athlete out of pain. Is it going to be sore? Yes. Is it going to be the excruciating pain when the joint is out? No. So you have to, by reducing that, you reduce where you can go from there, and then you'll refer them on to an orthopedist. All right. But the quickest, easiest one we're going to talk about first here is the patellar dislocation. All right, that's what is going on here. You are all licensed athletic trainers, so I'm not going to go over the anatomy and say, here's the patellar tendon. All right. So I'm going to assume we all know that, being that we're all licensed athletic trainers. So the thing about the patellar dislocation, all right, the thing that makes this the easiest of all reductions is that the patella is a sesamoid bone, meaning it's not connected to anything. All right, as you can see here, it's just connected into the the quadriceps and the patellar tendon. It just sits there, and it sits in a groove. So, as you can see from this old beat-up model here, you pull it out, as you were all taught, there's a big groove there. All right, that's what keeps the patella in. All right. So, another thing that we look at here in this next one, the reason why it is important to go ahead and reduce this is to limit the damage. Just like, say, the elastic on your underwear. All right, you can pull it out and it's going to pop back. But if you pull it out and leave it stretch for a long period of time, pretty soon it's going to lose that elasticity. All right, that's the same thing with these muscles and things like that. So if this patella, I believe, how do I go back on this?
With the
Back there.
you can go to the
Back
backspace
there on here?
or- Yep.
All right. When this patella is out of that groove that I just showed you in that deal, look at the stress it's putting on there. Also, if you look right in here, this ligament right here and the retinaculum right there, all right, you're going to put a stretch in that. All right, and the looser that is, the more frequent the dislocations are going to be. All right, so is there going to be damage? Is it going to be looser once it comes out? Certain. Once it comes out, it doesn't you know, it is never normal again. So when somebody says they have a bad knee or whatever, it's always gonna be that way. All right, we do that, you know, through your rehab and everything, we do that by strengthening the quad and tightening this down to keep it from coming out. All right, but our job becomes, you know, quite a bit more if that thing is out for a long period of time. All right, and as far as this location here, this is going to be one of the ones you're going to almost rarely have to deal with. Why is that? Because of the way everything is put together, a lot of times when it comes out, by the time you get to the athlete, it's already back in. All right, because this is the easiest reduction. What it is, because all you have to do here on this picture here, this is in the emergency room. All right, so there's no telling how long this patella has been out. All right, so, and the longer that patella is out, if you go back here, let's go back one more. Back here, this quadricep muscles and stuff here, once they're being stretched, what they're going to do is they're going to start spasming. All right, and that's with all these that we're going through. The shoulder, which is the last one we'll go through with the most complex, or even the finger. The longer that bone is out of joint and those muscles are contracting, the harder it is going to be to get back in. All right, and all these dislocations, the muscles are going to help you get it back in because that's where it's supposed to be, that's where it's meant to be, so the muscles are going to help you get it there. All right, so the longer it stays out, the harder it is going to be back in. That's another reason Dr. Foreman says you need to get it in there before those muscles lock down, because when you get to this point, this kid has probably already had multiple injections, maybe an IV, and at some points, like in shoulders, they have to put them all the way out just to get the muscles to relax enough to allow it to go back in. All right? So, like I said, on the patellar tendon, a lot of times you're not going to get it back in because by the time you get there, it's already going to be back in. All right? And have y'all ever dislocated your patella? All right. When it's out, you know it's out. All right. If somebody comes up to you, I think my shoulder's out, I think my finger's out, it's not out. Because when it's out, you know it's out. I mean, there's no question. A lot of times, if they say that I think I dislocated my patella, a lot of times that means it was subluxed. Subluxed, like I said, you're all certified, just means it came part way out and went back in. But once it goes out, all right, all you have to do, I say all, is straighten that knee back out, and the power of the quadriceps here will pop it back into place. Not to mention, when you come like that, you see the notch there. As you come back out, it all flattens back out. All right? When you put a stretch on this, it is pulling it down. So when it's out and you're pulling it down, the tightness there is keeping it pushed out of the groove. All right? So when you straighten it back up, it's releasing the tension along this tendon. It's going to pop it right back in. All right? If you get to the end, just straighten the knee. That's easy for us because our stuff's not hanging out the side. And it's very hard for an athlete to do. So it hurts. They're in a lot of pain. So trying to get them to relax and stuff so you can straighten it out. That's why I say a lot of times when you get there, it'll already be done. Because when they're flopping around in pain, they're going to straighten it out enough where the muscles are going to take care of itself and pop it back in. But if you get to that point where you can't get them in, this picture here, in the reduction, you see it tells you to go ahead and grab the patella, just kind of help it over that ledge. Basically, as you're stretching it out, it says to put your thumb there, and as it straightens out, to help basically push that thing back over. Very rarely are you ever going to have to touch it. Because once it gets straight, it's going to go where it's supposed to go, where it wants to go, and go from there. So that is the easiest reduction there is. All right, does that make sense? All right, Kara, why don't you come on with me? So when you come up here, let me grab this here. When you come up and as you know, the mechanism, a lot of times is hyperextension or a twist or a shot where it comes out. All right. So when this athlete, when the patella is out, she will have a bend in her knee, and this thing will be over here, and it is extremely. All of these dislocations, there's no doubt it's out. The deformity, you look at it and say that's not right. All right. And the size of the patella is that big. When it's sitting over here out of the way, all right. When you take that out of the way, and there's nothing there, there's just going to be a big. Okay, so it'll be obvious that it's out. Literally, all you have to do is grab the leg, and you can put your thumb right there on the lateral side of it, and straighten it out, and it'll pop right back in. So for patellar tendon, it's as easy as that. And like I said, when you're screaming about ow, 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 and you go to sit up, look how she straightens her leg as she sits up. A lot of that time, that's when it goes back in. All right, and it's kind of like popping a blister. When that thing pops, it's like. All right, and then the swelling starts, and then our job as athletic trainers, that's when it kicks in. But reducing it, all right, the worst that you're going to have to do is get over there and help it across. All right, and fighting the athlete. All right, trying to get them to relax. All right, just have them lay back and just try to keep them as calm as possible, and just pop it back in. All right. Any questions on the patellar tendon? That's pretty self-explanatory. I mean, it's that. Like I said, that is the easiest one. You're not going to have to fight it. And I'm about to say, I think I've put in. Let's see, I'm 24 years in, or 26 years in, long time in. I think I've literally only had to put in like 3. And my daughter was at a dance competition. I wasn't there. I put one in over the phone. Oh, it's out. It looks. Calm down. Have her lay back. Just slowly straighten it out. All of a sudden, you hear this. Oh my gosh! It just pops right back in. All right. But because without the umbrella of the orthopedic surgeon telling us to do it, technically we're not supposed to do it. But we're doing the guidelines of that just because the longer that thing is out, the more damage it's doing. The more it's hurting. All right, next is the hand, the finger. All right, here is your basic anatomy that we don't need to go into, or if any of this, if for some reason it's been a while and you don't understand, just let me know. And we can go back and go over it. All right, but the proximal interflexion with PIP, DIP, that's what we'll talk about here. But the most common one is the PIP, dislocation. Here's a picture of the dislocation. All right. Here is a very mangled hand and everything like that. But you see, here's all the bones without everything going with it. All right. Dislocation we're talking about here is there to go back. All right. And this thing, that is just a very mild one. A lot of times when you get to it, you've seen the pictures coming up like this, the finger will be facing a different direction or anything like that. The reason they say never do it, because you don't know if it's fractured or not. All right. And in discussing with Dr. Foreman about, do we go ahead and reduce it or whatever, he goes, if it's a fracture and it's going out that way, you want to straighten it out as quick as possible anyway. So you're not going to do any more damage or anything to it. All right. And then and just like with the knee and everything, once that thing gets back in, it's almost, like it's popping a blister. It's instant relief. All right. Instant relief from the intense pain. Don't get me wrong, it's going to be sore and stuff. And the longer it's out, the more pain it's going to be, the more those muscles will lock up and keep it from there. All right. So putting in a finger, what we'll do is, you can see that. Why don't you go grab the camera so we can do a close-up. Shane, let me see your hand here. All right. Let's bring the camera up. All right. Here is the joint that we're talking about here. And a lot of the times, like in the picture up there, it's going to be dislocated dorsally. It's going to come up. All right. Can it go palmar? Yes, it can go. It can go down just as well. All right. But the way you reduce this is a lot like being from the South. Have y'all ever milked a cow? Have you ever milked a cow? Have you ever milked a cow? That does not surprise me. You've never. All right. But what you're going to do is, all right, here's the joint that's dislocated. All right. So what you want to do is you want to stabilize above the injury, just like when you splint. When you splint, the guidelines are you stabilize the joint above and below the injury. Same thing here. All right. And when you come here, we're going to stabilize here. You're going to grab above it and put good tension in, and then you're going to slowly come down and pull it that way. All right. As you're coming down, if you see right here, all right, there's the head of the bone right there. You're going to feel that. All right. When you're coming down like that, when you get about right there, because of the musculature, what it's going to do is when it comes out, it's going to muscles always pull. They don't push, they always pull. So when it comes out of joint, it's going to want to pull it as far as it can that way. Okay? So it's going to be pulling there. So what you're doing there is you're coming down the length, and as you come down with your thumb, you're going to hit the head of that bone. What you want to do is use traction, pull it down, and just keep pulling it down like that, and then it'll pop back into place. Once it gets over this ridge here, all right, as you're doing traction and you're pulling it this way, it's going to be clear. It's going to pop right back down where it wants to go. All right. Depends how long it's been out and how far down it is. Sometimes it fights you. I've had to sometimes try to put it in. I've had to tug twice, and that athlete doesn't like it very much. All right. But you always start down, and just when you milk a cow, you start at the top of the udder and you come down. That's basically what you're doing here. You're starting here, you're putting it down, using traction like that. You find the head of that thing, try to push it straight back so it'll pop down in. And you'll see it, feel it, and sometimes even hear it pop right back in. You said you've reduced a finger before?
Once.
Have you? Have you ever reduced one?
Not that way. That's new. Didn't know that.
How did you do it?
Stabilize here and then pull the traction. And then
Well, you're doing the same thing. You're just coming from the side, all right. But when these muscles really contract and spasm up, sometimes just pulling the finger, like a jam, all of a sudden, just pull it so it goes back in. That's kind of what you're doing. The traction is the key part. The reason we milk it down coming like that is so you can get that head of that bone in all one fluid motion. Instead, because if you take it here and you're just jerking it, you could actually cause more damage and do that. And that finger's been jammed before, hasn't it?
Multiple times.
Got a little laxity in there. All right. So, and just like anything, you do not want a quick jerk. You want a nice, smooth traction, and let the muscles do the work. All right. And all of these, the muscles will do the work. You just have to put the bone in position to allow the muscles to do the work. Does that make sense? So again, it's freaky sometimes because there's one time with this where it was dislocated here, but it came under that finger. I mean, it came up and was dislocated. So what you got to do, the hardest part is getting them allow you to touch it.
Yep.
All right, and then like you said, you grab it here and pull it out, and then get it back straight, and then go and once this muscle, the head of that bone here clears this edge right here, it's going back in because that's where the muscles will pull it that way. Because you have extensors and flexors that are coming on both sides, one that pull it this way. All right. If you only had muscles on the top, then there's a chance it wouldn't come back in. But you got muscles pulling from the bottom as well. So when it gets back in that spot, it goes back down. And once it goes back where the good Lord wants it to go, again, it's instant relief. You go from Any questions on the fingers? Those are the two easiest ones. All right.
What the, say it dislocates in the palmar area, just turn it over and do the same,
Yeah.
same way?
It's a lot easier on the athlete and everything if you go ahead and keep it like that. Just as you're coming down here,
Just put traction.
just traction there.
Okay.
Because the main motion you want to go is away from the athlete, because you want to lengthen this out so the bones come across. So whether it's on top or bottom, you go from there.
Okay.
All right, and depending on the injury, you know, we've all heard the boutonniere deformity and stuff like that. So you may have this done and you may have ruptured this tendon as well. So once you get it out there and go from there, I forgot to mention also, always check the pulse before and after. All right, and on fingers, you know, the capillary refill. Does it go from pink to white? Yes. Does it come back? Good. And just check it with the ones that haven't been. Make sure they're all going. All right. And then, depending on the pain and things like that and what sport they're doing, you can do a collateral tape job by taping it back there to keep it there, because all that is stretched out. So if it gets hit again, it will come out again. So you want to get support there, then I usually buddy tape it. All right. And then if they feel like they can keep going, we go from there. And then, you know, textbook is to go get an x-ray and make sure there's no avulsion fractures. At least follow up with your orthopedist. All right, and the next day it's going to be sore and swollen and stuff there. But the longer it's out, the more damage it's doing, the more swelling you're going to have, and go there. I have had to send somebody to the emergency room for a finger, because it just would not go back in. It spasmed up so much that they ended up having to do it. So, you know, just because you can doesn't mean it'll always let you. Mm-hmm. All right, and if you just can't do it and you're causing the athlete too much pain and stuff, that's when you say, all right, then you splint and ship. But, you know, they hire athletic trainers to, you know, cut down the number of emergency room trips. If we can handle it here, there's no reason for them to spend $500 to do something you can do in 2 seconds. All right, and then you can do an office visit, which is just a copay and stuff like that, if for the follow-up x-ray and stuff from there. Any questions on the fingers? Is there anything that I did not go over that you have questions about? Mm-hmm. And like I said, when a joint is out of place, the deformity is very obvious, and it's sometimes scary. All right, because that doesn't look right. And stuff like that. All right, here we go. Next is the big daddy, the shoulder. All right, and have any of y'all put in a shoulder before? All right, that's the one that's the biggest one. That's the one that I know every one of your athletic training professors and stuff say, splint, get it out, don't mess with it. All right, Dr. Foreman, on the other hand, said get that thing in as quick as possible, because let's go to this next one here. As you can see, all the musculature and stuff around, which you know all, I'm not going to bore you with that, but when that thing's out, that's all being stretched. All right, and as you know, ligaments are very avascular, which means they don't heal very well, so they're not going to go back. All right, but the longer they're being stretched, the more they're being stretched. If they come out and come back, it does have a little bit of elasticity to it where it may bounce back enough where it won't be, you know, that's one less thing you have to fight. All right, so let's go back to here, the normal anatomy. You see where the ball and socket goes in there. As we've all been taught, the shoulder is a very mobile joint. That way you can go over your head over that. But the price for that is the stability. All right. Luckily, we have all these muscles and structures holding it in there. That's why you don't have more dislocations than you do. Because if you just go to the bony structures, there's not much holding it in there. All right. And dislocations, the majority of the time, they are an anterior or forward dislocation. All right, and depending on the sport that you're working, and things like basketball, most of them are in tank tops. You can see that from the bench. You can look up, that shoulder's dislocated, because as that big ball, Shane, come here for a second. Pull your sleeve up a little bit, show them guns off to the world. All right, that ball is right there, and it's right there, you can feel it. So if that thing is moved down from here, all of a sudden, when you push there, it's gonna feel like a big thing of mush. All right, and it'll be obvious because this nice round shoulder here will all of a sudden have a dip down because there's nothing there, because it's over here. All right. Unfortunately, in football, they're wearing all the padding and stuff like that. You're going to have to go through palpation. All right. You stick your hand up under there and you just palpate. All right. You find where the humerus is. You find the humerus and you just walk it on up. And if you're walking it on up the humerus, all of a sudden there's a big dip there. You know that it's dislocated. All right. And the quicker we can get that thing in, the better. All right. Like I said, here's all the musculature and all this. All of this wants to do is they want to keep, their job is to keep the humerus right there. All right, the head of the humerus right there. So once it's out, they're being stretched. So once you get it back to that close position, and the glenoid, let's go back here, that little cup right there, all right, has the lining, and it's got the cartilage and stuff around it. So once that head comes out, you've got to get it where to get over that lip and want to pop back in. All right. So the way we do that, all right. Now it all depends on where you find your athlete. All right. If your athlete's coming over and walking to you, they're up or anything like that, what you can do, all right, again, it is traction. All right, grab the humerus here, and a lot of times if you pull straight down, all right, let's go, if you pull it straight down, all right, and like I said, and it also says external rotation. So if you pull down and slightly external rotate, that brings the head, it brings the head of that humerus with external rotation, you're bringing it out like that, so it opens the joint up so it'll want to pop back in. Does that make sense? So by sitting down, pulling down, and externally rotating, a lot of times all that muscular just pop it right back in. All right? In a perfect scenario. All right? Well, does that always happen? No. But and let's see over here. If the athlete is on the ground, all right, so you're down on the ground. Yeah. All right. And it's hard. This shoulder's out. There's really no way you can get the traction and stuff on it. What you do is you take, this one's out, you try to sit the athlete up, all right, tell them to bend their legs, and then if you slightly put this hand right there, have him grab it with this other one, and just have them slowly lean back. They're using their body weight to do the traction. You can see as he leans back, just lean back. See how it's pulling there? That'll be the traction that you need to have that thing pop right back in. All right, so you don't have to do any of the work. All right, what you can do, help them stabilize it here, and you can do a slight pull there, and you can feel the humerus actually being slid out a little bit there. By having that traction there, hopefully it'll pop back in. And again, you'll see it, and sometimes you'll hear it, and they'll definitely tell you, oh, like just straight from there. All right. If you can't do that, then you somehow get them up, get some help, and we can come over to a table. And that's where they are here on that slide, lay them flat. We'll move all these pillows. And that's what they're doing there. They're doing the traction here with the external rotation. All right. If you have multiple people, all right. Another thing they say is have, get a sheet or something to wrap around the torso, and then you can also do your traction like this. All right, with a little bit of external rotation, because you're opening up the head of that humerus so where it wants to go back in, and you let all your musculature help you get back in. Does that make sense? Does that make sense? All right, and I have seen doctors when this thing gets locked down and they have to sedate you to get all that done. I've seen doctors, they have put their foot here and had to pull like this. All right, because go ahead, sit up. I mean, you have your pecs, you have your deltoid, you have all these muscles that want it to go right there. And after you put it in a stretch, they're going to start spasming up.
Mm-hmm.
All right, that's why it's so important. The longer you wait, the more these muscles are going to say, forget it, and start locking down.
Mm-hmm.
And then you have to sedate them just to try to get the things to relax. All right. Another way you could do is get them and have them roll over on your stomach. You can put your feet on either, it doesn't matter. All right. And have them hang off the side. Come squat. Just have that thing there. And the end of the phone. All right. And as you have them there, pull down and have the traction this way. All right. In the slides here, here's the one I just told you. If they're on the ground, let their body weight help. Of course, they have it tied, and that's it, perfect. Next is put like a 5-pound weight. All right. Textbook, which is not always real world. I cut off here, but he said with this technique here, put it there, and within 20 to 25 minutes, the muscles will relax enough to go back in there. We don't have that. All right. But putting here allows you to stabilize above while you're doing the traction to allow that thing to come back in. Does that make sense?
Mm-hmm.
All right. Now, I want you to slide around, put your feet there. Carol, I want you to come up, and I want you to practice. I want you to pull down and externally rotate. And when you're doing that, if his hand, see if you can do it with one hand. I want you to feel here, and you'll feel the humerus move out. Your traction, you want to come straight down.
And then turn,
Yeah, and then externally rotate. Why are you externally rotating?
so I can move forward.
Yeah, because you want that head of the humerus to come out here and say, here I am. I want to go back and just flop in there.
So that would be like that, like sulcus sign. It's like that special test, right?
Yeah.
Just add a little bit of the external rotation.
Yeah.
Yeah. Oh, okay. Okay.
And that's what you're doing there. When you pull down, you're putting your fingers right here to see how much of a gap is there.
Yeah.
All right.
Okay.
That just tells you how lax it is there.
Mm-hmm. Yeah.
All right. And then because the mechanism is usually coming back out like that because you see it. I mean, you can feel it right there.
Yeah.
So we're trying to recreate that is to get that here and open it up so that thing and allow the muscles to suck that thing right back in.
Okay.
Does that make sense?
Yeah.
That's
All right, switch with her.
That's so much simpler than I thought it was going to be.
Again,
Yeah.
when you're reducing these muscles, the muscles want it to be in the right spot. You just got to help it get there. All right. Well, just start by pulling straight down and then just feel around. You can feel the gap, right?
Yeah.
Now that gap's already going to be there.
Yeah.
All right. So you're gonna pull it down, and then when you externally rotate it like that, you're basically lining the head of the humerus up to get back in there.
Yeah. Okay.
And the thing that you're fighting is these muscles wanting to spaz up. Does that make sense, KR?
Yes, sir.
Because that's what you're fighting against, is the muscles keeping you from getting the bone back where it wants to go. And that's why it's so important to do it as fast as you can as well.
Sorry, that's cool.
All right. Do you want to feel? You can do it on my shoulder.
Yeah.
Since the girls are all in long sleeves.
Oh,
Yeah.
just have a jacket on.
What
Sorry.
you feel right there. Now pull down.
You
But-
can
but-
see it on you.
Yeah.
You can- Sorry.
Lack of muscle. That's why. Appreciate you
Sorry.
pointing that out.
I'm
No,
sorry.
but do you know?
Yeah, like you can feel it just kind of pump out a little bit or slide down a little bit.
And two important things to do once you're done is the nerve that runs through there. All right, that textbook, they're all worried about you can pinch that nerve or do whatever. It's going to be the feeling out here on the deltoid. So once it's all in and everything like that, check the feeling out here on the deltoid, and then check the distal pulse and circulation to make sure if all of a sudden it starts turning blue and stuff like that, then that's an emergency 911 to get them there situation. All right. And again, you should always follow up with your orthopedist and go from there. All right. Now, those are the three easiest. The one I talk about, like the elbow and the knee and everything, it is the exact same concept. All right. When they do the elbow here, when it dislocates, it's going to come down and back because the triceps and stuff are going to be pulling it back. So again, it's the same thing. You will feel the edge of the bone there. You'll traction down and pull it back and pop up. Just with the elbow, there's a lot more stuff in there that can get pinched and things like that. Is why I would be a little nervous. And then of course you have the femoral artery in the knee. All right, in the ankle, you just grab the calcaneus and basically do a drawer. Do it back out, and it's again, the muscles want it to be in the right spot. The anatomy wants it to be in the right spot. So if you just give it a chance to get to that spot, it'll go back in. Does that make sense? But the longer you wait, the more those muscles are going to lock down and go from there, and not allow you to.
Yeah.
That's when you have to. All right. But on the knee and elbow and stuff like that, you need to make sure before you try to reduce or anything, you've got to check circulation and things like that, because that becomes an 911, get them out of here ASAP, not don't pass go, don't get $100. It's a life-threatening or a appendage-threatening issue. All right, but fingers and shoulders and stuff, more than likely it's just a pain deal.
Right.
All right. Would y'all feel comfortable putting a shoulder in now?
Much more comfortable than before. I've seen it before where like people do the hanging off the table and do it themselves, and I just didn't understand like why they were doing that or how that all worked. So
But-
it just makes sense like what you're saying.
Yeah,
So,
because
really simple.
as you saw here, all that musculature wants it to be right there.
Yeah.
That's what it's built for, to stay right there. So you just have to allow, and as it's pulling, if it's not in its hole and it's pulling down here, you just got to get it up and get it over that ledge where it'll go back in.
Right.
Same thing with the finger and the,
No, that makes sense.
all right? The shoulder's just a bigger joint.
Much simpler than what I thought, for sure. Like I thought that
Oh yeah, well,
was so much more.
you've been taught from the very beginning in athletic training. Don't do it. That's a doctor's job. Da da da. But our doctors are saying you can do more damage by leaving it out and letting all these muscles and things stretch and stay stretched, as opposed to putting it back in. All right. If you put it back in and there's a fracture, say you fractured your finger or the socket is fractured or anything like that, it's still going to be fractured. All right. Putting it back in is not going to keep it from being fractured. All right. If it is fractured, they go to the emergency room. Yep, it's fractured. They're still going to put it back in. All right. And now you're dealing with the fracture and all the stretched ligaments and muscles and things like that, as opposed to just the fracture or the labrum or whatever. Any questions? Any problems? Any concerns? All right. A couple important things is make sure you check circulation before and after. All right. Check nerve functions like in the shoulder and things like that. And And trust your hands. Feel it. Get out there. You can't be afraid to touch it. All right. We've all witnessed surgeries. Are they gentle in surgery?
Definitely not.
All right. You can't worry how you're going to hurt them more. All right.
Yeah.
And you just got to get the trust of your athletes and say, hey, this is going to hurt, but it'll feel so much better when I'm done if you just let me do it. All right. Because if they tighten up, now you've got a muscle spasm plus a contraction to try to fight through to get that muscle back. If you relax one time, I can get it done. Okay? Any problems, questions? Problems, questions?
Good.
Well, thank you. And if there's any other things like that that you've seen or that we want to go over as a group, we need to, you know, don't hesitate to ask. I don't want you to get to a spot going, I always wondered about this, but
Right.
if it's something I know to do, we'll do it. If I don't, we'll get somebody in here to teach all this.
Cool.
All right?
Thank you.
All right. Well, thank y'all.
Thank you.
You can cut it.